Welcome to the LowCarbUSA podcast, where we seek to inspire you to help us build this community. I'm Doug Reynolds.
And this is Pam Devine.
I've got Beth McNally and Matt Miernik here with me, who are a couple that are very, very involved in the type 1 community. And they were very, very involved with the type 1 day that we had in our Boca event in January. Very much involved in our planning of that day and very much responsible for how well it went and how valuable we felt eventually that this was going to be to the community. So much so that we even decided to take all the videos from those talks and actually put them out on YouTube outside of our gateway, because we just felt like they could be so important for this community. So since then, we've been talking about having a podcast to chat about it, and just things have just never worked out until now. So welcome, Beth and Matt, and maybe start with Beth. And I just would like you to talk a bit about that event and, you know, how you feel that it's going to impact the community.
Yeah, well, thank you, Doug and Pam, and thank you for inviting us today too. Matt and I originally got into this realm of nutrition and type 1 diabetes management because we have a son who was diagnosed with type 1 diabetes in 2015. So when I heard originally from Pascal Lemieux, who was one of the organizers that worked on things with Doug for the Boca Raton Society of Metabolic Health conference in January, this past January, we were really keen to get involved. It felt sort of like, Christmas or a big holiday where somebody paid attention to the type 1 diabetes community, and we went, you want to do a whole one-day workshop on type 1, and we can put a whole bunch of people in the room, both people with type 1, both people who do not have type 1, or those living with type 1, and we can talk about, how we can make things better, and improve the quality of life for people with type 1 diabetes. Because many of us have found that using nutrition has had a major impact on the outcomes. We certainly found that for our son. So the Boca Raton workshop, it was sort of like a big love-in. It was a big, almost like what I would, you get in the room with people who share the same path that you do. And we also had people online, Pam, you were taking questions from people who were writing in and asking questions. And it's a very nice place to be, because in the world of type 1 diabetes, when you're a person who is diagnosed or a family who has a child who has been diagnosed, it can feel like a very lonely place, because there may not be a lot of people who have type 1 diabetes. And if you decide to do a nutrition therapy, such as a low-carb approach or therapeutic carbohydrate reduction approach, you might not know anyone else who does that. So then everybody ends up, feeling that they're going it alone. So when LowCarbUSA hosted, the type 1 diabetes workshop in January 2024 in Boca Raton, there were a lot of us in the community who were really excited. So we had some fantastic speakers. Pascal got people from all over the world. Dr. Ian Lake and Suzanne Schneider came from the UK, and they're leading experts in type 1 there. And Suzanne has a special interest in eating disorders. And we had Dr. Evelyn Bourgeois from Quebec, who came down as well, from Canada. And Pascal and I came from Canada. And then we had many, many people from the US. So Dr. Tro opened up the day. And then we had a number of speakers. Dr. Westman spoke, and Dr. Saiviz. Who am I missing? I spoke at a parent. I don't know if this was your idea, but we had a parent panel. I think this was your idea, Doug. We had a parent panel, and Lester Hightower and I spoke about our two sons who had type 1 and how we had managed to help them normalize their blood sugar levels through nutrition therapy, and by also using Dr. Bernstein's protocol for people with type 1. So it was a great day, and a lot of positive things have come out of that, because Doug and Pam, you decided to actually have those, talks recorded, and they're available free on YouTube. And that's a huge thing for the type 1 diabetes community, because people need to find that they have somewhere to go, a soft place to land where other people understand them, know what they deal with on a daily basis, and have hope for them to be able to not be on a blood sugar roller coaster all day and to try to have better diabetes outcomes. So it was a really special event. It will always go down in my heart as, you know, one of the best days, surrounded by a lot of people. And I also found it fascinating, and maybe you two can speak to this. So many people in the room did not have type 1 diabetes. And I think it was quite eye-opening that they realized, you know, people don't always understand what the day in the life of a person with type 1 diabetes is like, not even sometimes for other, you know, that person's family members or friends. You know, the number of injections they have to take, or if they have an insulin pump, you know, they're changing out that pump every 2 to 3 days. You know, there's a lot of work that needs to be done in order for them to be able to manage the condition. So it was nice to hear from people who didn't live with type 1 diabetes and how much they learned from the day.
Now, Pascal helped me understand through that weekend what it's like to be a type 1 diabetic. You know, that he kind of described it as having a completely separate parallel pathway going on in your life 24/7. So on top of all the decisions that we make it on a daily basis in our lives and our work and with our children and all of that, you've got this thing going on in parallel that you're making thousands of decisions a day based on your particular status at that moment with regards to your type 1 diabetes, and how you know, he helped me understand as well that, you know, we say, or it's kind of, people think that the suicide rate amongst police and first responders is the highest in the nation, and I believe that that's not really true. That it's actually higher amongst the type 1 diabetes community because of how hard it is to live with it, and that some people just can't cope with that. And that all through that weekend, I just became more and more aware of how we just didn't have a clue what these people like right in front of us were going through on a daily basis. It changed my life completely that weekend. And it helped a lot. And then you talked about people in the room. One of the things that really stood out to me was like, because we actually did 2 days. We had a workshop on the day before,
Yes,
which was more of a practical thing and a how-to thing, and then we had a whole day of lectures on the first day of the actual event. And it was during the workshop on the day before that I remember this guy come up. He's a long time supporter of ours. He comes to all our Florida events, I think, and I think he's retired now, ophthalmologist or a physician of some kind. But he got up to the Q&A mic and he said, you know, that I have learned more about type 1 diabetes this afternoon than I have in my entire career. And
Medical school.
to me, that was like, wow, this is amazing. You know, from medical school, any training that he's been through in his whole practice and his career, he learned more in that afternoon than he had done in that time. And that really made it stand out to me as to that, you know, that how impactful this weekend could be and was for that community. And one of the things I think that prompted me to suggest that we even have this talk was we got on Zoom shortly afterwards, and we were talking about it. And Matt, it was I think you had a lot to say about it. I was even guilty of this in a way, is that the type 1 community was perceived as being combative sometimes. And going through this weekend, I realized why, where they've been so sidelined and ignored by the medical community, and that they became like overly protective of their. I mean, a lot of the people that are really prominent in that are not doctors. They're engineers, like you know, they're not doctors. But they've gone in and looked at the physiology and looked at the data and decided that there's a better way to manage this condition. And what we had, what you seemed to vocalize so well was the need to try to change that so that it was more inclusive of the doctors and more, let's reach out and teach them about it instead of pointing fingers at them and telling them that they're useless. And maybe you can elaborate more on that, because you had a lot of thoughts on that, Matt.
Yeah, Doug, the best thing about the workshop and obviously the focus on type 1 diabetes at the conference was the fact that it was finally brought to light, the condition, people's struggles. And as Beth mentioned, and as we all sort of realized over that sort of weekend, how much the families, those diagnosed, and the condition itself is very much in the background to the sort of larger issues within metabolic health, whether it be cancer or insulin resistance and type 2 diabetes. And type 1 diabetes is almost sort of like a forgotten issue. And as you pointed out, with Pascal saying, how many decisions those with type 1 diabetes have to make, it really is a relentless medical condition that you actually have to take, you have to look after 24/7. And it is really mainly a complex medical problem. Once you actually take out an important hormone like insulin out of the equation, you really get a bird's eye view, as I like to say, into the body as to what truly happens. What does the body really want to do when you take out this major hormone that really regulates a number of different functions in the body, and very, very important functions. And it's not just about blood glucose control. There are a plethora of functions that insulin plays. So once you actually take that out, you get this bird's eye view into the body of what it's trying to do. And because of this medical sort of metabolic condition, type 1 diabetes is really at the center of nutritional therapy, I believe, because when you take out that, hormone that regulates food, what you basically eat, the best thing that can actually help manage that condition is actually food. And I think this is where the type 1 diabetes community has been trying to shout from the rooftops, those of us that have figured this puzzle out, to say, look, we understand we have insulin therapy, and it's without insulin, you don't live. There is no life without insulin. But in order to help manage this condition, make it easier on those diagnosed, on the families managing it, food plays the central key role. And, within the community, we sometimes may seem that, we're out there and we're angry and, we're sort of lashing out at people or, the medical community, because we just want people to hear us that, look, food is the biggest factor here in order to help manage this condition. You are, in a sense, carbohydrate intolerant. You naturally can't process carbohydrates. And the current, management strategy just continues to say, just keep doing what you're doing, eat how you want to eat, and just dose insulin and everything will be right. And it's not. And it's not. It doesn't work that way. I mean, insulin, as much as it's a life-saving medication, is nowhere near perfect. We're not, it's not being administered internally, right? We're having to administer it from the outside of the body. And there are so many issues, from absorption to how that insulin was, held, transported, its potency. And then we're trying to make all of these elaborate physiological decisions as to how the body's going to process the food you're going to eat, how that's going to come into your bloodstream, and then how that insulin from outside the body that you're about to inject is going to effectively work, along with, numerous other hormones that are working in the background as well. And it's like we use this sort of analogy in the type 1 diabetes community. Imagine having a burning house, and on the one hand, this burning house, is basically burning because you've got these logs on, inside the house. well, what you're being told is, just keep doing what you're doing, keep piling on the logs onto this fire. Oh, and here's a hose that you can just put this fire out, but try not to douse it and flood the house. So in order not to flood the house, you throw more logs on the fire, and then you just add more water, and it's just this constant battle. We're like, hold on a second, why don't you just take out the very thing that's causing the fire or erupting the fire, which are the logs, which effectively are the carbohydrates, and therefore you won't need as much water to put that fire out. It's just such a very logical, sort of explanation. And this is why we can come across as being so vocal, but quite rightly, as you pointed out, Doug, look, a lot of it's not actually, the doctor's fault. And the reason for that is that the guidelines are just so behind the times. The guidelines continue not to look at type 1 diabetes as this metabolic condition of, of carbohydrate intolerance. That you should really reduce the very thing that's flaring up the condition to make it easier to manage. And we keep saying, no, that's not the case, and we just need people to listen. And this is why the conference that you put on, the workshop, and obviously the 2 days, brought light not only to the day-to-day management of what those diagnosed have to go through, the challenges they have to go through, and also, though, how successfully people are managing it through a nutritional intervention. And this is where your position paper and all of the people working on that are so important to bring that to light. So hopefully, bit by bit, we can chip away and get some guidelines, which will hopefully come through to the medical community, so that more doctors are confident to say, you know what, I will prescribe this if somebody's actually interested, or this will be the first go-to, as in, you know what, it's not just insulin therapy, there's a nutritional component to help you not only manage day to day and make your life easier, but improve your overall health outcomes long term. So this is where it's, in a way, this sort of chicken and egg, because many within the community get upset at the medical many in the type 1 diabetes community get upset at the medical community, as in, why can't you see this? But the medical community also says, well, we don't have the education, we don't have the guidelines. And many of them are afraid to step outside, their lane, for fear of medico-legal issues, because there are no guidelines backing the decisions they're trying to make. And they don't have the education. They just don't have that nutritional education on how to manage this condition. So this is where we have to show empathy to the medical community, try and work with the medical community, but also empower them with the tools and the education to go, right, now we understand the medical condition. We now see how nutrition actually plays such a vital role in this. It really does. And now, you know what? Let's help our patients, let's help those diagnosed and their families manage this better. And at least all we're asking for is provide this as an option. Provide this as an option to the families and those diagnosed. Let them choose, but provide it as an option, show them the outcomes, and let them make an informed decision.
So Adele Height, who was instrumental in developing the clinical guidelines that we have published on the SMHP site, one of her visions was to develop condition-specific addenda, what she called them, like, so that, you could, for every condition like type 1 diabetes, there are nuances and differences and things that are special to that particular condition. And so you made reference to it a bit earlier about this position paper, and that's kind of, it's been published, well, it's been submitted for publication now, and that basically is our first condition-specific addendum to the guidelines. And I know Beth was, you as well, I'm sure were very, very involved in actually developing that. So maybe I think it's a really good segue. I really wanted to talk about this, so let me know, Beth.
Yeah, so I was thrilled when I heard Dr. Tro mention that the SMHP, Society of Metabolic Health Practitioners, was going to issue a position statement on using therapeutic carbohydrate reduction for type 1 diabetes. And it's basically, sort of a call to action for the medical community to reevaluate the prevailing nutrition therapy in type 1 diabetes and have more broad consideration for therapeutic carbohydrate reduction. So advocate for open access and clinical support. So if a patient, like Matt mentioned, if a patient comes forward and says, I would like to do this, I would like to eat this way, can I please have support, from my diabetes care team or my diabetes medical professional in being able to do this. And if I can just take a step back before I talk about the position statement. So we, in our family, our son was diagnosed with type 1 diabetes. No one in our family had type 1 diabetes. I remember being in the, emergency room and Lachlan was just diagnosed. And in my head, I'm going, what is that? I don't even know what this is. I know what diabetes is, but what is type 1 diabetes? And so, you then just, whatever your doctor tells you, you're just so grateful that you have help, right? I mean, by day 2, you're giving needles multiple times a day to your child, right? So it's a huge learning curve at the beginning, and you're trying to figure out how much insulin, not enough insulin, and then you're counting all of these carbohydrates in foods, whereas the day before you never ate a food and even realized there were carbohydrates in it. It's a huge learning curve. And so we did that for a few weeks. I'm like, this makes no sense. His blood sugar goes up and then it comes crashing down, and it goes up and it comes crash. And he feels horribly all the time. And he's acting like he's fighting with his little brother, and he's struggling to, being on this blood sugar roller coaster. And so, Matt and I were looking for anything we could find, and we finally found a YouTube video. It was a presentation from, I believe it was Low Carb Down Under. I mean, this is back in 2015, so we're going back a ways. And Dr. Troy Stapleton was a radiologist and type 1 who'd been diagnosed with type 1 himself, tried to manage the conventional way and switched to a low carb. And all of a sudden we went, you can change the food, maybe we can change the food. So then we tried it and it worked. This is a long story short. And then as a parent, you just have to do whatever you have to do for your child, right? Or as an individual, you just have to do whatever you do so you feel better on a daily basis. So you just start making these changes as safely and with as much information as you can figure out. And it's based on trial and experience. Oh, that didn't work. Oh, my blood sugar went high. Oh, my blood sugar went low. And you figure it out. And then once you kind of make even, whether it's a little bit of improvement or a lot of improvement in blood sugar regulation, because that's what you're aiming for. I mean, I saw my grandfather struggle with type 2 diabetes and have his toes amputated. I knew from day 1 that this is going to be my son's life if I don't make sure his blood sugars are normal. I don't know how to do that, but I know that I have to figure out how to do that. And so, but there's a lot at stake. It's not just what happens today, it's what happens 5, 10, 20, 25 years down the road. So we just do this as individual families and patients. And then you get mad because you realize, why didn't anyone tell me this from day 1? Why do I have to figure this out myself? And yes, it's easier because there's social media now. But in 2015, there was nothing. And you want the help of your medical team because you want to make sure you're doing it safely. And, I mean, we were probably, what is it, Matt? For a year, we were like, is our son going to grow? Are we doing damage? We were really worried, right? And when you think about it, it's a steak and chicken and eggs and salad, and it makes logical sense, but you're wondering why they didn't tell you. So then, in my personal experience, 9 years later, the fact that I show up at a conference in Boca Raton in January, and a prominent, metabolic, medical expert says, we're writing a position statement asking our colleagues to be more open and provide clinical access for people with type 1 diabetes who decide that they want to follow a low carb way of eating. It was amazing. And that's why I asked, do you need any help? Is there any way that we can provide input into this so that it's, it has as much impact as possible. So the position paper is currently under review. There is a team of authors who, I respect greatly, and I'm honored to be on that list. And basically what we're saying, and as a mom, it's still, because I know, Doug, you got very emotional when you talked about how much that conference impacted you earlier in this podcast. But there's a line in that paper, in that position paper, that says, we must not settle for the status quo in type 1 diabetes management. And this paper was written because right now, based on how type 1 diabetes is being taught, there are only about 21% of adults who meet the American Diabetes Association A1C target of 7.0%. And there are only about 17% of youth with type 1 diabetes that meet that. So, remember when we went to school, if you got a 21% or a 17% outcome on a test, you would be in a lot of trouble when you got home that day, right? We cannot have the conventional system that's not working, not at least go, wait a minute, we need to figure out what's going wrong here, and we need to make improvements. So the SMHP position statement on therapeutic carbohydrate reduction for type 1 diabetes asks that there can be open access and clinical support for this nutrition intervention. And it's asking for increased research efforts into studying therapeutic carbohydrate reduction, specifically in type 1 diabetes. It's asking to facilitate immediate access to education, nutrition resources for patients, clinical guidelines, and clinical training for clinicians. And to me, it seems evident. And as a mom, I'm thrilled. I'm also thrilled because position, statement is something that patients can bring, to their diabetes care team. And this happened in the type 2 diabetes realm, right? I mean, it was a lot of patient driven. Some people were getting results and they started to spread the word. And the same thing is happening in the type 1 diabetes community. So I'm very grateful to SMHP and to LowCarbUSA for hosting the conference in Boca Raton that allowed people to come together and write this paper.
Yeah, and if I could just add to that too, those statistics that Beth gave with the 17% of, children and 21% of adults meeting the ADA's 7.0 A1C target, that is still almost double like what normal blood glucose levels are. Like that's not even close to being normal. And there are numerous studies out there which actually show that health complications from elevated blood glucose levels commence far earlier in terms of at much lower thresholds than that 7%. And we know from studies such as the DCCT, which was a groundbreaking study a very long time ago, that basically came out and concluded that, look, the goal of type 1 diabetes management is to maintain blood glucose levels as close to physiologically normal as possible in order to avoid health complications. So, even when we're looking at these ADA targets of 7%, they are nowhere near, they're almost double what normal happened to be. And those high elevated numbers, we're getting fewer than 1 in 5 children even meeting those. And it's interesting because at the conference and also at your workshop, Dr. Belinda Leonards presented a number of times, and she was the lead author of a major research paper back from 2018 that studied a group of adults and children, so almost 400, that adopted a very low carbohydrate way of eating to manage their type 1 diabetes. And the average A1C was 5.67%. It's miles ahead of what the current conventional management strategy is for those with type 1 diabetes. So this position paper and this position statement is so important because we really need to get something out there into the medical community that puts the research that we already have that works, that shows that this works, to be that stepping stone to further research, further adoption of guidelines, further adoption of this becoming an option, because it is a viable option. I mean, our son, and it's amazing because sometimes I think in the research and the medical community, we look at anecdotes and sort of go, oh, they're just anecdotes, they're ends of ones. But you add up all of these ends of ones, which we're all doing roughly the same thing. And that's a very powerful population of people that have superior results, not only for A1C, but just overall quality of life, where you're not chasing these up and down blood glucose levels. And you know what, to your point, Doug, that you mentioned, earlier about, suicide rates, and things like that, you're more in control. You understand what's happening in your body. You're not sort of bewildered as in, well, why is my number gone up to 300 and all of a sudden I've got double arrows down, coming down to 65, and that is your day. That is your day. I mean, I sometimes say to people, any day that somebody with type 1 diabetes wakes up in the morning is a good day. Because those overnight hours, right, when you are asleep and you've injected yourself with insulin, none of us really know what's going to happen. We really don't. But we can decrease and minimize those risks through nutrition by getting rid of those flames, decreasing the amount of insulin that we inject, which is highly unstable and volatile and very unpredictable. And these guidelines are so important for that, to be that step, getting that out into the research world and also into the medical community.
That's huge. And it just, to give people the peace of mind to have that more stable, regulated. I mean, if anybody in this world were given a tool that would help decrease their stress in any aspect of their life, let alone every aspect of their life, you would think that that should be an option somewhere, right? So it was really great to have physicians like Dr. Laniers from Boston, she in Boston General or Mass General, big hospital in Boston, doing research and writing research papers, and then also having an NIH grant that she's received to do future research on the next biggest project that's going to be happening in the space, so that more people will learn. And it was really great to have one of our goals at the Symposium Metabolic Health since the very beginning, when we realized there were so many practitioners who didn't understand the power of therapeutic carbohydrate reduction, that patients and lay people were coming to the conference who had never found, like you, a physician who understood their disease, that could be very highly affected and benefit from therapeutic carbohydrate reduction. It became a really big goal of ours to make sure that we were educating as many practitioners as possible so they could be there for their patients. Now, this is going to provide that education. But can we go back a step? Like, where did this misconception that carbohydrates are so necessary come from in the beginning? Like, you have to have a lot of carbohydrates, so then you have to give a lot of insulin because so your blood sugar doesn't go too low. But then there's that risk that the insulin is unstable and can be too strong, and then it brings it down too low. So then you just have to, for some reason in the community of endocrinology and diabetes education, they've gotten to this point where they feel like a higher blood sugar is safer, that to avoid those dangerous lows. Because we all know that the higher blood sugars are kind of what are causing a lot of the risk and complications are coming from the high blood sugar. So I think diabetes educators and endocrinologists want to keep those blood sugars higher and educate families and patients to keep those blood sugar highs to avoid the lows. But
yeah, I think it's a great point. And, even reflecting on the discussion that we just had, over the last, short while here on this podcast, if you're coming into this and you don't have a background in type 1 diabetes, a lot of what we're saying would be over your head, right? It's it's complicated. So for everyone to understand, the challenging part about type 1 diabetes is that you have to inject insulin into your body so that you can keep your blood sugar levels as close to normal as possible without having your blood sugar go too low or too high. So if your blood sugar goes too low, that's called hypoglycemia. And that means that there's not enough glucose in the body in order to meet the cell's needs. However, people get very scared about that, because if you had a really severe, which is rare but possible, severe hypoglycemic event, it can lead to seizure or coma, or in the worst case scenario, death. So you can imagine as an individual diagnosed with type 1, or if you have a child diagnosed with type 1, you're constantly worried that this one moment in time, which is why Matt brought the, discussed the overnight sleeping issue. It's this fear that's ingrained in you from day one. Do not let your child's blood sugar levels go too low. You might lose them. And then on the other end of the spectrum, you can't have blood sugars being chronically high, because that leads to high glucose levels in the blood, leads to damage. So it damages the tissue, damages the blood vessels, which carry blood all around the body. Because you have to remember, blood is from the tip of your head to the tip of your toes, right? So everywhere that excess glucose is, it's basically making everything sticky within your body, and it makes it harder for the cells to work properly. So now you have, I always think about it like a sticky sugar film covering your blood vessels and covering your organs. And now you're doing damage. And the leading diabetic complications are blindness, kidney disease, which can eventually lead to kidney failure, and things like nerve pain, like really painful, tingly nerves pain that you feel, sensations that you feel within the body. So as a person with type 1 diabetes, you are constantly trying to find that fine balance. And it's actually not very safe when you add things to the body that make your blood sugar go high, because then you need a whole bunch of insulin to bring that down. But you have to always make, every time you inject insulin, you're making a decision. How much insulin do I need? And where you inject it on the body means it absorbs differently. So there's all these things that you're having to think about. Those are the decisions that Doug was talking about earlier. So now we have this really tight range we're trying to get in. And like Pam said, when you add carbohydrates, they break down into simple sugars, the most abundant of which is glucose. So as soon as you eat those carbohydrates, any kind of carbohydrates, a lot of times people think that whole grains or rice, etc., are good for you, except that they turn into a lot of glucose in the body. And now you need a high dose of insulin to be able to bring that level down again. So what we do in therapeutic carbohydrate reduction is we add fewer carbohydrates into the meals, and then we need smaller amounts of insulin. So now we have less room for error on the amount of insulin dose that we have and how it might react when injected into the body. So that if our blood sugar goes a little bit low or a little bit high, that can still happen, but the swings will have less amplitude. They will not be as great. And so then we're keeping things more safe. And I don't recommend that anybody try to get normal blood sugars if they're adding high carbohydrates in, because like you say, Pam, you should be scared of hypoglycemia, right? Because you have so much insulin in your body. And I'll give you an example, because people don't really, well, what do you mean by that? So when Lachlan was first diagnosed and he would need to eat a meal, and he had a little body, little 9-year-old body, as you can imagine, and we might have to give him 60 grams of carbs for dinner. So one night we put a bunch of rice in a wrap, a bunch of chicken, and we put it in a wrap and he ate it, 60 grams of carbs. And he had 5 units of rapid acting insulin. So these days we might give him the same meal, except instead of white rice, we put cauliflower rice in, and then we'll put a low carb wrap around that tortilla. So now instead of 60 grams of carbs, I might have, and mind you, he had a lot of rice at that one meal. So, he might have 10 grams of carbs. So now I need a lot less insulin. So now when his blood sugar starts here and he eats, he might go up to here and then he might come down again versus, and so he doesn't feel as badly and it's safer. And I always think that, what your CGM does, like when you have type 1 diabetes and you have a CGM, not everyone needs a CGM, but if you have one, you can see it fluctuate. And I always think about that fluctuation when I see it in my clients is, that's what you're saying, Pam, that's a stress level. Like how stressful is it to see this, versus seeing this, right? It's a lot less stressful. And we actually had the Institute of Medicine mention when the dietary guidelines were issued, they actually had a section on, and they decided that they would pick the minimum number of carbohydrates that humans need, in order to function. And they picked 130 grams based on an extraction of what they believe that babies need when they have breast milk. And it actually is not true that we would need to have 130 grams of carbohydrate, which would turn into enough glucose for the body to use. Because if we understand physiology, we actually understand that if the body needs glucose, the liver can produce it for us. Otherwise, while we slept, or if we went 2 days without eating, we would all die, right? So we know that we actually can produce enough glucose to survive. So yes, we can eat carbohydrates, and we can have, healthy foods that come from healthy carbohydrate foods. The hard part is we're not trying to say all carbohydrates are bad. We just want to choose the carbohydrates that make it easier for us to manage type 1 diabetes. And when you go to your doctor, your diabetes care team, as a parent, they think that carbohydrates are essential. And I went back and did a Master of Science in Nutrition and Integrative Health degree, 2 years after Lachlan was diagnosed, because we had normalized his blood sugars, but I couldn't understand why. Like, why? What's happening in the body that we've been able to do this? So I go back to school, and even my textbook, and this would have been 2017, says carbohydrate is an essential nutrient. Like, that is in the dietetics and nutrition book, right? So in medical school and in nutrition school, we are still being taught that carbohydrates are essential. And what we really mean is we need to eat enough food. We need to have enough energy. That is essential to keep us alive. And we can choose a variety of foods to be able to do that. And if the body needs glucose, it can produce it on its own. But I think it can be very confusing for practitioners when their textbook says one thing, and then someone walks in the door of their clinic and says, I don't want to eat carbs anymore, or I only want to have a few carbs a day. I can see how that would be like, so how are we going to go? How am I going to deal with this, particularly when I don't have guidelines that say I'm allowed to do this?
So, and Matt, you probably have something to say about this. If you're switching from, I guess, so in the situation where you're going to go low carb, you're going to talk about switching the body's fuel source. So people don't understand that you can have a fuel source from protein and fat and a little bit of carbohydrates. You don't eat no carbohydrates normally. You have some cauliflower, which has some carbs in it. You have a low carb tortilla, which has some carbs in it. You have broccoli, and people don't realize there's carbs in broccoli and lettuce and salad and all these things. So you can switch your body, that fuel source. And Matt, you were talking about logs. I often think of fuel sources as logs and kindling, like the small little pieces of sticks and grass and dried stuff that actually burns really fast, and then it's like, and then it dies down and you need more. So people always think that's 3 large meals and 3 snacks, because they've got all this kindling that burns down so fast. So go ahead, and I know you had to comment. Matt.
Yeah, no, Pam, and as you asked the question originally, like, where does, and Beth sort of spoke to this, where does this notion that carbohydrates are essential? Beth's actually she's done 2 YouTube videos on this specifically, because she went into the literature behind this recommendation, right? So where is this apparent recommendation where carbohydrates are essential, which Beth, mentioned in her dietetics nutrition textbook with no reference? It automatically says carbohydrates are essential, and each human requires a minimum of 130 grams a day, period. No citation, nothing. So when you actually go backwards and go, okay, so where did that actually come from? As Beth mentioned, the Institute of Medicine, which is an organization in the United States, which they sort of come together and they write the literature and the scientific evidence behind the dietary recommendations. So they underpin all of the nutrition guides. And Beth will speak to this more because I'm a layperson. She's the expert on this. But when you dive into the dietary reference index, which is written by the Institute of Medicine, in there they actually say that the minimal amount, or the minimum amount of carbohydrates necessary for human survival is unknown. It's unknown, right? Like, they don't actually have a number, and they basically say, as long as you eat sufficient amounts of protein and fat, humans don't need carbohydrates. So carbohydrates are completely non-essential, unlike protein and fat, which are both essential nutrients. Again, Beth is the clinical nutritionist here, so she'll speak to it more. And then obviously that got extrapolated to a lift out in the back of that guide, which is a summary guide, which just provides its recommendations. And that recommendation is 130 grams. And that's what gets put into the dietary guidelines. And that's what goes into, all of the medical literature. So when you go into a doctor's office or a dietitian, all they read, similar to what Beth had in her textbook, is carbohydrates are essential and you need 130 grams of carbohydrates. That's false. That is completely false. It is not backed up by any data, and the data that underpins these dietary recommendations basically say it is unknown and that carbohydrates are not essential. And that's effectively.
Yeah, and the one, the nice piece of evidence that our family has, and so many other families like ours, and so many other adults with type 1, is that they're living and they grew. Even
really tall, by the way.
Yeah, Lachlan's 6'3" now. So, but that was a fear of ours in the very beginning, right? So I want clinicians to ask these questions. I want them to go, well, what about nutritional ketosis? Well, what about hypoglycemia? Well, what about, great, let's have the conversation, right? I don't want anybody to feel like they can't ask. There was, during COVID, there was a study done in Canada asking dietitians and nutritionists, whether or not they feel comfortable supporting patients with low carb diets. They called it therapeutic carbohydrate restriction was the term that was used. And 2/3 of the dietitians said that they did have a lot of training and they felt that they had zero to little knowledge, about how to do this. And, that is a symptom of their association needs to be able to train them so that they can help people. This wasn't specific to type 1. This was just, low carb in general. And, I welcome questions. I've worked with many people in different areas, and I've had some of the, brightest minds come to me and say, I think it's too risky for type 1. And then I explain, why it's actually less risky? Because we end up reducing mealtime insulin or changing the type of insulin that's used, and it makes it a lot less risky. And the only reason we might have hypoglycemia, regardless of your eating the way you eat, is because you have too much insulin in your system, right? So we have to remember, and we say this in the paper, and this is why I think Pam and Doug, that the position paper, the SMHP position paper on therapeutic carbohydrate reduction for type 1 is going to be so helpful for clinicians, because we actually start with, here's the position, here's what the current standard of care for medical nutrition therapy is in type 1 now, and some of the outcomes related to that. Then we discuss therapeutic carbohydrate reduction as a nutrition therapy and what the evidence currently tells us. And we see that there's improved glycemia. And we see that there is no evidence of greater risk of hypoglycemia or diabetic ketoacidosis. And there's even potential for reduced frequency of and time spent in hypoglycemia. So the clinicians will have those resources, those research papers that they can go to, and they can refer to that so that they can learn about it. And, we have to keep educating people, because the biggest question also becomes, well, what do you do with insulin? I have a lot of families that I work with and do nutrition education with. And, when they go back to their diabetes care teams, they're like, I would love to support you. We have to work on insulin dosing together, because I don't know how to dose. I don't know how to change your insulin regimen in a way that, and so we start slowly and we start safely, and everything is trial and error, but we need to know how to use insulin. And even as parents, we're not taught how insulin medication works. It's pretty scary. We're like, here, use this for the 24-hour background basal insulin, and here, use this for meals. And you're going to count carbs, and you're going to use this much if the carb count is X. But you're not taught, well, wait, when does that insulin medication start working once I inject it in my son's body? When does it peak, and when does it leave his body? No one ever mentioned that, right? Because it's a lot of information to have to know. Right. And so you really also do need to have a general understanding of how to use insulin so you can use it safely, regardless of how you eat. And I think it's also really important, too, that people know that therapeutic carbohydrate reduction can be many things, right? It can be very low carb. It can include vegetarian ways of eating and like Mediterranean ways of eating and ketogenic ways of eating. There's a whole bunch of things that can all fall under that larger therapeutic carbohydrate reduction umbrella. So there's lots of room for everybody. And I really think that, you know, not every patient will want to do this, and that's okay. The position paper is just saying if somebody wants to do this, they should be informed that it's an option.
And this is how it works. And this is if you are Indian and you want to eat Indian foods, let's try it. Maybe this is what will happen if you don't eat rice with your food. And this is what you could incorporate differently and use cauliflower rice. Or in culturally, like Mexican food. We live very south in very southern US, and there's a lot of Mexican food, and that's culturally what everybody would eat: corn tortillas and rice and all the things that go along with meat and vegetables that may be raising blood sugar in type 1 and type 2 and the other chronic illnesses where there's a lot of insulin on board. Can we actually address this double diabetes that type 1 diabetes patients could get, because it's a really big issue in developing type 2 diabetes in the general population, but our type 1 diabetes families and children and adults who are using a lot of insulin are also now, it's also contributing to a second disease state, theoretically.
Yeah, and so double diabetes is sort of, it's a phenomenon that occurs when someone's diagnosed with type 1 diabetes, so they have a type 1 diabetes diagnosis, and then over time, because not everybody, there are many adults that are diagnosed these days with type 1 diabetes, or also something called LADA, but the majority of people are diagnosed when they're children that have type 1 diabetes, and generally in most populations, it tends to be between 10 and 14 years of age. So you can imagine that most 10 and 14-year-olds, when they're diagnosed, they're fairly metabolically healthy, right? Like they tend to be, often they're fairly active kids and they're of normal weight. And then what happens is over time, when they use the conventional management approach and they follow like a standard Western dietary approach, they develop what is called double diabetes, which basically has the characteristics of insulin resistance and metabolic syndrome, which is characteristic of type 2 diabetes. So it's almost like you're diagnosed with type 1, but because of the way you've managed and the high amounts of insulin that you need to cover those high carbohydrate, standard diabetes management meals, you end up having the same metabolic profile as somebody with type 2 diabetes. And so it's referred to as double diabetes. And it amazes me because we're now using therapeutic carbohydrate reduction for type 2. And we're like, look, it can manage, it can manage blood sugars more easily, it can do this, do that. And I'm like, okay, type 1 and type 2 are two very different metabolic conditions. However, those foods still have the same impact on blood sugars. So why wouldn't you think that what works for one would also be beneficial for another? It'd be beneficial for really any human, So I think that's a great point, Pam. We do mention that, in the paper too. Like we want to be able to use nutrition therapy to just keep people healthy in general and also prevent them from having type 1 diabetes develop into double diabetes.
Yeah, because you don't want the necessary treatment for type 1 diabetes, that missing piece, or someone needs insulin, but if it's being given at higher dosages, that the body and the cells actually become resistant to that insulin, and then the doses need to be higher and higher, and then the damage that comes along with that.
Yeah. And with the paper, we need this because we need doctors to be able to support people. Because when your child is diagnosed at 10 or 14, or, I have children, my families have children that were diagnosed at 2 and 3 years of age. I mean, some of them are diagnosed at very young age. And then they want to change the food and they go and they're like, oh, you're not allowed to do that. Right? That's not allowed. Like that does not make me feel comfortable. We don't have anything that'll, and then, parents already have to learn how to switch the foods and deal with things like, how am I going to manage? Because the majority of the population, follows a standard American diet, right? And we're all unhealthy, like, and the majority of us are unhealthy. So now you're already navigating that. But if you go back to your doctor and they tell you no, or I have a ton of families where one parent wants to do this and one parent says, no, the doctor says no, we'll be fine, to have the A1C at, whatever it is. And so we need the clinicians to also light the way that things are possible, because you gotta, we always say in the type 1 diabetes community, choose your hard. Was it hard to figure out how to change Lachlan's food? Yes. I mean, I just did a post on Facebook on this week. I'm like, Matt was like, we need to do something. And I'm like, yes, we need to do something because this is not working. But we can't change his food. He won't be like his friends. He'll feel left out. How do we do this? How do we, and then we decided to trial it, and instantly overnight his blood sugars changed. And in my head, I went, yay. And I was happy. And I went, damn, we're not going to be eating cake anymore in the same way we used to eat cake, right? I mean, there's a lot of
Pizza and donuts and all those things that are normalized.
Yeah, but
you
I'm
have
like,
to go to a birthday party every
no
weekend
choice.
and have cake and pizza.
Yeah, and then it's funny because now sometimes my parents ask me questions that they want to know from Lachlan, and so I go and ask Lachlan because he's now 18. And a big discussion we have is birthday parties. How do you manage a birthday party? Do you let them eat the cupcake? Some parents were like, what, at a birthday party this one time, they're gonna have a high carb cupcake and we'll manage. Others are like, no, I want to bring a low carb cupcake for my child. So families do many different things. And I said to Lachlan, like, what do you remember of birthday parties? Because it's very emotional for parents to send kids to birthday parties, and they're worried that they're going to look different and feel different. And Lachlan and we used to bake I baked a low carb cupcake, and I used to send it with Lachlan when he went to birthday parties. He's like, oh, Mom, I don't remember a birthday party. I don't know. He's like, I don't remember going to birthday parties. Like, he doesn't even remember. And meanwhile, I would be at the birthday parties and I would be just kind of like raging, like, oh, like, why did I have to cook a whole set of cupcakes just to come to this silly birthday party? Like you struggle as a parent because you worry about all those things. But what are your choices? Like, he has this medical condition. We need to have him have a quality of life so he can have children, and he can, like, once you learn the statistics on erectile dysfunction in adult males with type 1 diabetes, you're sure as heck going to do everything you can to make sure that if your child wants to have his own children, you're going to do whatever it takes to get there. And that's just one thing. I want him to be able to see for the rest of his life. I want him to not sit in a kidney dialysis clinic, every second day. Like, and then once you adopt the habits, you go, okay, that took a while, but I developed new skills, I developed new habits, and now it's our new normal, and we enjoy the way we eat. But I do want parents, like, if you're struggling, like, you're not alone. Like, it's weird at first, and you need to find community, and you need to find support from your clinicians. We've had clinicians, like the first doctor's office we went to, they were like, we've never done this before, but we will help you. And they were amazing. And then the next doctor told us basically that we were idiots and we were trying not to give him any insulin, and that we were withholding insulin from him. We're like, we know he's going to need insulin. We're not trying to take away his insulin. And by that time, we'd already had the diet in place for 6 months. And he was like, if you don't want to serve them carbs, just give Coke Zero. And I was like, that's great advice. Like, but as a parent, it was a much different clinical experience. Support versus, like, they made us feel like we were the biggest jerks in the world. And they say it right in front of your child.
I want to go back to the support thing in a second, but I just wanted to check with Matt. He'd been trying to say something for a while.
No. I wanted to, sort of discuss that double diabetes component bit, because, when Lachlan was first diagnosed, just like any parent, you go through a lot of distress. I mean, mourning, loss, it's like a fire hose of information is coming at you. And as Beth mentioned, within 24 hours, you're injecting something that you have no idea how it works. Like, it's very much just trial by fire. So I remember the day, when Lachlan was diagnosed, and that night I basically pulled the Dr. Google all night, as in, so what are we up against here? Like, what's going on? And I actually happened to stumble across double diabetes. And it shocked me. Like, that's really what stopped me dead in my tracks. And the reason for that is that I said to myself, wow, you mean that this condition that he has, where he needs this, life-saving medication to live, he could become resistant to in the future. And how's that going to work? Like, will that end his life sooner? Because what he's injecting himself with when he gets older will no longer work, or it won't work as well. And then you go down the nutritional path of looking at the obesity rates, and then you look at the type 2 diabetes rates and obviously insulin resistance, and go, okay, so how do I stop him from being insulin resistant? How do I not have him, have those type 2 diabetes characteristics, so that this life-saving medication that he will need to take for the rest of his life works the way it's supposed to work, in terms of his body not being resistant to it. And we know it. I mean, this is where this therapeutic carbohydrate reduction and type 1 diabetes goes hand in hand, because you're not inflaming the body through too many carbohydrates and high dosages of insulin, which is what's happening in a healthy person that doesn't have type 1 diabetes, where if you, as we know, among other things, if you consume the large amount of processed carbohydrate foods, your body is, secreting so much insulin that over time, the body says, enough. I'm not going to take this insulin anymore, because I have nowhere else to put all of this glucose, by the way. I'm not going to function to it. So that's what stopped me dead in my tracks, and that was early on, going, oh my goodness, that was the first thing. I think the second thing is that, in the nutrition space, and this is learning, more from not just this journey with Lachlan, but even, Beth's studies, and also too, Doug and Pam, what you're doing with, LowCarbUSA in terms of trying to break this sort of dogma when it comes to nutrition therapy, is that it's amazing to me. It's always amazed me where eating a steak and salad is so dangerous, apparently. There's such an aversion to, well, no, but you need a bun with that, or, you need, a heap of potatoes or a heap of rice with that. So you mean to tell me that if I just take that out and eat the protein and say the salad, that's going to be bad for me somehow? And I think we need to break this down, because it just doesn't make much logical sense. Like, I'm just eating natural, real whole food. I'm actually eating essential nutrients in my protein, which is an essential nutrient. And then I'm having lower carbs or sort of carbohydrates that are still nutrient dense, but just won't spike blood glucose levels. I don't see the harm in that. And for some reason, we have this, I guess, I have this sort of saying, nobody ever said, you eating toast and your cereal for breakfast was going to be dangerous. But the second you eat bacon and eggs, for example, it's like, whoa, hold up a second, you shouldn't do that. So that's the other thing with the type 2, like with the double diabetes, and then the whole food sort of dogma, where it's just normal, real whole food. That's what you're eating, And one final point I just want to make, when we look at Lachlan, he's 18 now. As Beth mentioned, he's 6'3". He's healthy. He's graduated high school. He's, his regimen, we have him, or he is himself now, as he's 18, on a very low carbohydrate way of eating. So he's less than 30 grams of carbohydrates per day. And, the doctor said, look, your brain won't function on that. Well, he's graduated high school and he's soon off to university. They said, well, you wouldn't be able to perform athletically. Well, he was a high performance swimmer. He actually qualified for the Swimming Canada Paris Olympic swimming trials, right? So, he's and this is all on 30 grams of carbohydrates, eating protein for growth, and eating low carbohydrate vegetables. And, we have this evidence in our community of hundreds of children, thousands of children across the world, and adults practicing this, who are lean, who are healthy, who are growing, who are developing. And there seems to be pushback against that. And I hope that this is where, the position statement and the paper will change that, to get people to stop and go, hold on a second, have we got this backwards? Because we know day to day, it is backwards. It really is backwards. Actually, one final thing too. Sorry, we talked about that insulin bit too, and sort of the higher sort of target ranges. And, Pam, you sort of talked about, doctors sort of mentioned for children to have those higher sort of numbers. And a lot of that it's because they're trying to provide a buffer, because it's a fear of hypoglycemia. That's why they're actually doing it, because they know how unstable and how variable that insulin is. And we also know that once it's injected, we have no idea what's going to happen. We really don't. Like, you could go up, down, sideways. So the smaller the dose of insulin, the more you're able to control that variability, right? And this all stems from the diabetes control and complications trial, the groundbreaking DCCT trial, where what they found was that those on an intensive insulin regimen, so they didn't change the food, like they had two groups, they had a control group and then they had an intensive insulin group. And these were type 1 diabetic subjects, so people diagnosed with type 1 diabetes. And what they found was that those with the intensive insulin regimen, where they tested their glucose more and they injected more insulin as a result, their A1Cs came down and they were less likely to have complications. But the downside of that was that they found that there was an increase in mortality and from potentially hypoglycemia. And that is where this sort of fear of hypoglycemia has come from. But the variable that they never changed was, well, let's reduce the amount of glucose going into the bloodstream to reduce the amount of insulin to then create that safety barrier. Instead, let's keep the carbohydrates high, let's keep the dosages high, but then let's keep your blood glucose targets high to create that buffer that way. And then what's sometimes looked upon by the medical community is, well, you know what, those health complications, they're a consequence of the condition. There's nothing that we can, it's just going to happen. And this is the other thing, and this gets back to your point, Doug, of why sometimes parents and adults that are diagnosed with type 1 diabetes get so upset. Well, we say, but that's not good enough. This shouldn't be an unintended consequence. We know we actually have tools at our disposal that, yes, we're going to have to continue to inject insulin for the rest of our lives, but we can lead happy lives, healthy lives without complications and with a safety barrier, because we're using less insulin, because there are fewer carbohydrates, we are more normal and stable, we don't have to constantly check our blood glucose levels, and we grow happy, healthy, avoid double diabetes, and we hopefully avoid those complications.
Yeah.
Thrive
And
be competitive, because Lachlan's not the only child that I've seen in this and who have been such an incredible example. Let me be 83's River is a competitive tennis player. Dave Dykman. Little Dave Dykman is just as tall. Lachlan and him were probably even 6'3", 6'4", and he's competitive in college and playing polo. These kids are not just sitting on the couch playing video games trying to figure out what to do with their blood sugar. They are thriving and they're competitive. Go ahead, Doug.
Yeah, no. So I wanted to go back to finish off. I think to go back to what Beth said about support, because I think that is so important for anybody that has themselves or their child or whatever that gets diagnosed with this, that there really is an amazing support system out there. I think more so than any community of other, even cancer, and that I feel like that your community is so tight. And I think then just a little anecdote story that came out of that event was you and Lester did that talk about the parents' experience. But then we also planned to have on the last day just a little round table, like for people to ask you questions and stuff. But in the meantime, one of the ladies, I think she's a doctor and she's been to a couple of our events, got news through that event that her son was in hospital and he literally nearly died. And teenage son, I believe, and was diagnosed with type 1. And she was hysterical. She was crying and, trying to get a flight to get home. And her husband said, look, you're at a conference where they got to focus on type 1 diabetes. Maybe you should stay there and see what you can learn. And so she did. But that last day kind of turned into a therapy session for her. And it was amazing. The just fact that it just happened there, that her son ended up in that situation while she was at this conference, and how she basically had this immediate support group around her, which most other people don't even know exists, let alone have this. You just like put your arms around her as a community and said, yeah, we're going to help you. So I think the big thing is there's a lot of, this community is huge, and I'll put some stuff in the notes as well, but maybe you can just talk about if people are struggling with this, or they end up in a situation like this, doctor, where it suddenly gets sprung on them. I suppose that it's always suddenly sprung on you, no matter when. It's like, where should they turn to sort of join your community and get the support that they so badly need?
Yeah, that's a great question. We actually did a post. So I don't think we said this at the beginning, but I went back to, I went back and did my degree, and I'm now a licensed dietitian nutritionist and certified nutrition specialist. And I have a private clinical practice called T1D Nutrition. So if you look on Facebook, T1D Nutrition, I just did a post this week listing a whole bunch of people that communities you can join, blogs you can look at, presentations from LowCarbUSA, Low Carb Down Under, presentations from around the world, because you're sort of like a sponge at the beginning. People are pretty numb at the beginning. You're trying to process what is happening to yourself or your child, so it's a lot to take in. And people sometimes approach it in two different ways. Some people say, I just have to learn to do the basics right now. It's all I can handle. I can't even believe, this has happened. And then, over the course of the coming weeks, they can access that information, Doug. Or they're like, right away from day one, just tell me what I need to do. Sometimes a person's diagnosed and they're either slower onset type 1 diabetes, which is called LADA, or their child's in honeymoon, and they can, what's called a honeymoon period. So the child's pancreas is still producing some insulin on its own. So they might need a little bit of insulin from injections, but they also have a little bit of insulin. And so they can use that diet right from day one to help preserve the beta cells. And so there are many different places, that you can go, various Facebook groups that you can join. And a lot of people go there first, Doug, and they just lurk and read and figure everything out. And then obviously there are, clinicians, that help people. I have a parents program, for example. Diverge Diabetes has an adult program for people who want to follow Dr. Bernstein, and you met Allison Hershidi and Lisa Lanassa. They run that. Plus they also have a number of wonderful coaches. There's Type 1 Diabetes Family Center, which is in Western Australia. They support people managing diabetes in a number of ways, and they will also help with low carbohydrate nutritional approaches. So there are people out there. There is more and more. I know Dr. Saiviz. I was introduced to the work that his clinic is doing for adults, and I've met his wonderful dietitian as well. And so there are places that you can actually seek clinical support. And many people are doing this on their own. Like, one of the things that I encourage people to do is say, you really need to understand how your body works, because you live in it. And then it's like, think about it. I've thought, is this the only medical condition where you're trying to replace a hormone and you use it every time you eat? Like, it's such a unique condition.
A whole bodily function that you actually have to manage as a human being externally.
Yeah.
Okay, I think this has just been amazing. I knew it was going to be, but it turned out to be as I expected. We are planning, I'm going to edit this and everything and have it all loaded, and I'm going to pull the trigger when this paper is actually published. So we coordinated with that release. So yeah, go to the smhp.org, and there, if you don't get our notices and stuff, and then you click on journal, there's a menu option there, and you can go and find the latest paper, which will be this one because it'll just been published. Yeah, so if you're listening to this, the paper's just been published, and go and check it out and take it to your doctor, as Beth said. Use it to get the support that you want to have, right? It's your choice, and you need to be able to have your choice recognized and acknowledged. So thank you so much for taking the time to do this. I know you guys are hectic busy moving to Australia or something. Yeah, it's been brilliant, and can't wait to see where this whole thing goes, because
I would love to see, like, now we have a position statement. Now we have to provide diabetes care teams with more information on how to do this, right?
Maybe
So that's got to be our next step.
Maybe that's what we need to work on, is start talking about how we approach those, because you've got to get them to agree to listen to you, right? To let you come in and give a talk about it to their staff or whatever. A different way how we can do that, and get it out there.
A lot of general practitioners, like a lot of adults see their general practitioners, right? So the general practitioners are doing everything. So they need resources from us.
Yeah.
So they can still support people, but they have such little time.
Right. So they
So
need to be able
how do
to
we
point people to stuff that they know that they have faith in, and trust that it's good information.
Yeah.
So yeah. Awesome.
And
We'll work together
yeah.
to put some more resources together. You have them, other people have them. Let's kind of get them. There's lots of different places that people can find them. If you have to do that.
And Doug and Pam,
education
can't
sources.
thank you enough, like, both for, putting on the workshop and such a focus in Boca Raton for type 1 diabetes, because we really do feel like we're sort of off in the corner a little bit. So, having it center stage so that people can understand a little bit more, and how therapeutic nutrition is the key to managing this condition. Irrespective of all the technology that's out there, it still pales in comparison to what therapeutic nutrition, and how much therapeutic nutrition moves the needle in terms of positive outcomes, not just metabolic outcomes, but emotional, mental, physical, and so forth. So staging it that way was brilliant to bring it to the fore, and obviously your platform to get this message out to more people and through the position paper out to the clinical community is just so vital. So want to really thank you from the community, for everything that you do for all of the various medical conditions, but especially what you did this year for the type 1 diabetes community. It really meant a lot to us all, so thank you.
When it was suggested to me to do, you have type 1 as the focus day for the following year, that was back in 23, I thought, okay, I didn't have anything else in mind, so I thought, well, why not? It was literally that blasé. I had no idea how it was going to change my life. So yeah, thank you to guys for putting on such an awesome event, and helping me put on such an awesome event. And
and thank you, Doug and Pam, because what you might not realize is the prevalence of type 1 diabetes is growing so much that they predict that there could be about 17 million people worldwide by 2040 with type 1.
That's insane.
Right. Is that the autoimmune component, where they don't really understand why people are getting so many more autoimmune diseases in general, let alone type 1? But that is an astounding number. Like, what is the percentage of growth over between now and then, even in the last 15 years? In
Canada, it's 4.4% a year, which is much higher. And most of the families I see, there's a lot of talk of the role of COVID. Right, like oftentimes they don't exactly know how diabetes is caused. There's a genetic component in there, environmental factors, but certainly they're studying the impact of COVID on the development of type 1 diabetes too. So I know we don't have much time and we need to wrap up, but I think that SMHP is very well placed to continue to lead the field in being open to the ways that we can use nutrition therapy to help people get better diabetes outcomes and to have a better quality of life, throughout their adult years.
And at the very least have a choice, right? That
Yes.
in the management protocol that they want to follow and be supported in that way by their medical team.
That's
not-
right. And
not
then have the
happening right now.
clinicians feel more confident, right? People get scared when insulin's involved.
Yeah, through that weekend, I mean, there was a number of doctors there that were like that guy that came up and said like how much he learned in one afternoon. But so many of them like talking to me separately, saying like, I used to just pass a type 1 patient on to somebody else. I was afraid to treat them because the existing protocols to treat it were dangerous, were resulting in a lot of danger to those patients. So a lot of people came to me and said, thanks for doing this, just because now I have the confidence. And there was a lot of them, not just one or two, said, I have the confidence now to treat a type 1 patient if they come into my practice. Which
and those videos are available for everybody to watch currently. So anybody listening to this who wants to change their practice, who wants to have the patient who wants to bring this to somebody and keep spreading the information, the position paper. If you understand type 1 diabetes, list yourself on the SMHP's listing database of practitioner and how to find you around the world. It's an international database. Beth has a listing. Get in touch with the people who are working in the space and ask questions and learn so that you can find the confidence to help more people, because people are looking for more practitioners. And so, go ahead, Beth, because I saw you.
No, so the only other podcast we've done that has gone this long is with Rob Cybers, because he starts talking and doesn't stop. It's been incredible. This is amazing. I really hope
we
people
did warn you. We did warn you before we started.
You did. But I'm so glad. I really hope that people are listening to what I'm saying now. So it means that they've listened through to the end.
A long time.
Amazing. All right. Thanks, guys.
Thank you, Doug. Thank you, Pam.
Okay.
Thank you, guys.
You've been listening to an episode of the LowCarbUSA podcast. You can support us on Patreon at patreon.com/lowcarbusa.